You know, usually when we talk about healthcare or medicine, there's this, I don't know, this underlying expectation of precision. Like we want it to be like engineering.
Right, very mechanical,
Yeah.
very clear cut.
Exactly. Like if you have a patient with a broken arm, the process is incredibly straightforward. You take the x-ray, it shows that jagged white line right across the bone, and the doctor just points at the glowing screen and says, well, there it is, broken.
Yeah, it's highly binary, it's clean, it's observable, and there's a definitive protocol for it.
Broken or not broken, you slap a cast on it and you know almost exactly what the outcome is going to be in like 6 to 8 weeks. It's a really comforting way to view healthcare. I think we just really like things to be visible and completely predictable.
Oh, absolutely. I think human nature craves that kind of certainty, especially when the stakes are high. We want a clear enemy like a virus or a fracture and a really clear weapon to fight it.
But then, and this is where reality hits, you actually step onto the floor of a long-term care facility or a bustling hospital unit, and suddenly that precision, that whole X-ray machine mindset is completely useless.
It totally falls apart.
It really does. When you are looking at the day-to-day reality of patient care, you are looking at a safety landscape that is, honestly, it's murky. It's incredibly ambiguous.
Very muddy waters.
Right. Because the biggest dangers you face on a random Tuesday afternoon aren't always some complex rare disease. Sometimes the most lethal danger in the room is a spilled cup of water on the linoleum.
For a pair of ungripped slippers left in the wrong spot.
Yeah. Or a frayed electrical cord hiding behind a bedside table.
That is the absolute definition of environmental muddy waters. The threats are everywhere, but they're completely ordinary. They hide in plain sight. I mean, they don't look like medical emergencies until the exact second they become one.
Welcome back. If you are stepping onto the clinical floor soon and you're feeling the weight of that responsibility, today's deep dive is tailored exactly for you. We are so glad you are here with us. This is the CERT Prep Academy CNA Exam Prep Deep Dive, and we are right in the middle of our 11-part series.
Working our way through all 6 of the NNAAP written exam topics.
Yep. And just as a quick reminder, each of these sessions stands completely alone. So you can jump around to whatever specific topic you need to study right now. You really don't have to listen to them in chronological order.
Which is how adult learning should be, honestly. You tailor this entirely to your own study plan and, where you feel you need the most reinforcement.
Today we are tackling Session 5, and that is Safety Part 1, Fall Prevention and Environmental Safety. And okay, let's unpack this right out of the gate because we really need to set the stakes here.
The stakes are high for this one.
Super high. If we look at the 2016 NNAAP exam content outline, which is basically the architectural blueprint for what you are actually going to be tested on, safety and emergency, falls under the broader category of basic nursing skills.
And if we connect this to the bigger picture of your overall exam strategy, basic nursing skills makes up a massive 39% of the entire exam.
39%? That's huge.
It is a truly huge chunk of your grade.
Yeah.
Out of the 60 scored questions you're going to face when you sit down at that computer, about 23 of them are going to come directly from this one overarching category.
It's basically make or break for passing. But, I think it's important to just pause here for a second before we get too deep into the test-taking strategies, because safety isn't just about passing a multiple-choice test.
Right. It can't just be academic for you.
Exactly. I'm glad we're touching on this, because if you only memorize facts for the test, you will freeze on the floor.
You absolutely will. You have to internalize it.
Right, because it's the absolute core of what a CNA does every single shift. You are protecting vulnerable lives. You are the literal eyes and ears on the floor. The doctors might be there for, 10 minutes a day?
If that. And the nurses are juggling charts and a dozen different medications.
But you, the CNA, you are in the room. When we talk about these safety protocols, we are talking about preventing real devastating injuries to real people who are entirely relying on you to look out for them.
That's beautifully said. And what is really fascinating here, and what makes the exam actually quite brilliant, in my opinion, is that the questions are specifically designed to test your real-world judgment.
They aren't just trying to trick you with abstract stuff.
No, not at all. They aren't looking for high-level medical theories. They want to know what you will do when you are standing in Mrs. Smith's room. It's 2:00 a.m., the lights are dim, and something suddenly goes wrong.
So let's jump right into the most common thing that goes wrong. The absolute #1 risk you're going to face on the floor. Patient falls.
It's a daily battle.
It is. I want to talk about the anatomy of a fall. How do we even identify who is at risk before they even try to, swing their legs over the side of the bed?
Well, this is where your clinical observation skills have to be incredibly sharp. Because identifying a high-risk patient isn't just about walking into a room and looking for someone who simply looks frail or physically weak.
It's not just the obvious physical stuff.
Exactly. It is almost always a combination of compounding factors. Yes, advanced age is a baseline factor. As we age, our proprioception naturally declines.
Proprioception, that's the sense that lets you touch your nose with your eyes closed, right?
Precisely. It's your body's ability to sense its location, movements, and actions in space. It tells your brain where your feet are on the floor without you having to actively look down at them.
Which we totally take for granted.
We do. But when that declines, your balance gets incredibly wobbly. So age is a factor. Vision impairment is another huge one. If a patient has macular degeneration or severe cataracts, they literally cannot see the obstacle in their path, so they can't avoid it.
Makes sense. But what else?
The critical and honestly often overlooked factor that the exam loves to test on, and that you will see every single day in practice, is polypharmacy.
Polypharmacy. That's taking multiple medications simultaneously.
Yes. Let's look at a classic comparison you might see in a test scenario or just in real life on the unit. You have an 82-year-old patient in room A. They are on 6 different medications. They have poor vision, and they occasionally experience mild confusion about where they are.
Okay, got it. 82, 6 meds, poor vision, slightly confused.
Right. Then, in room B, you have a 60-year-old patient who is recovering from major abdominal surgery, but they have absolutely no other complications. They aren't on a massive cocktail of daily meds, and their vision is perfectly fine.
The 82-year-old is the higher risk, even though the 60-year-old literally just had their abdomen cut open.
Without a doubt.
Yeah.
And it seems counterintuitive at first. You'd think the surgical patient is the most fragile.
Because they're in pain and recovering.
Right. The 60-year-old has a localized acute issue. They might be in significant pain when they move, but they are alert, their proprioception is intact, and their blood pressure is stable. The 82-year-old has what we call compounding systemic factors.
Let's break down that polypharmacy aspect a bit more, because I think people underestimate what happens when you mix 5 or 6 pills together in an older body.
It creates a biochemical traffic jam. Let's say our 82-year-old is taking a diuretic to help with fluid retention.
A water pill.
Right. That medication is designed to make them urinate frequently. So right off the bat, they have an urgent recurring need to get to the bathroom.
Which means they are going to be highly motivated to get out of bed, whether they have your help or not.
Exactly. The motivation is high. Now, add an antihypertensive medication to lower their blood pressure. A really common side effect of those is orthostatic hypotension.
Oh, where you stand up and the blood rushes from your head.
Yes, meaning when they sit up or stand up quickly, their blood pressure drops suddenly and the room starts spinning. Finally, let's add a mild sedative or an anti-anxiety medication that makes them slightly groggy.
Wow. Okay. So you have a patient who desperately needs to pee, who is groggy and confused, and whose blood pressure completely tanks the second they stand up, plus they can't see the floor very well.
It is the perfect storm for a catastrophic fall. That is why polypharmacy is such a massive red flag on your shift.
Okay, so if I'm the CNA assigned to this patient, what early warning signs am I actively looking for? I mean, I know I can read their chart at the start of my shift, but behaviorally, what am I watching for when I'm just in the room?
You are looking for physical unsteadiness when they simply shift their weight in bed or in a chair. You are listening for signs of confusion, like them repeatedly forgetting where the bathroom is or asking what time the train is leaving. But a major visual red flag is a patient reaching for items that are out of bounds.
Out of bounds? Like what?
I mean, leaning way over the edge of the bed, stretching their center of gravity to the absolute limit just to grab a tissue box off a distant bedside table. Or trying to snag their TV remote that fell on the floor.
Ah, I see.
That behavior indicates impulsivity. It tells you they might try to self-mobilize and get up entirely without asking for help because they don't recognize their own physical limitations.
Now, wait, let me ask you about the opposite end of the spectrum. What about the patient who is constantly hitting their call bell? You know the one.
Oh, we all know the one.
The one who rings it every 5 minutes to ask for a sip of water or to ask what time it is or to adjust their pillow by literally 1 inch. Doesn't that indicate they are highly agitated, restless, and therefore a major fall risk?
It's a really common assumption, but actually, no.
Yeah.
And this is a vital distinction for you to understand, both for the exam and just for your own sanity on the floor.
Okay, lay it on me.
A patient who is frequently using their call bell is demonstrating that they possess insight into their situation. They know how to seek help. They are actively asking for assistance rather than attempting to do it themselves.
So even if it's, let's be honest, slightly annoying to answer the bell for the 10th time in an hour, it's actually a safety win.
Absolutely. From a purely fall prevention standpoint, frequent call bell use is a fantastic sign. It means the safety system you've put in place is actually working. The patient understands that you are their bridge to whatever they need.
That makes total sense. They are communicating instead of acting impulsively. Which actually brings me to what I like to call the holy grail of CNA safety. Because if there is one specific answer that shows up constantly on the CERT Prep Academy practice tests, it is this: keeping the call bell within the patient's reach.
It is the ultimate environmental fix. I cannot stress this enough. The call bell is your absolute first line of defense.
Right, because if it's out of reach.
If it is not physically within their reach, if you leave it resting on the bedside table just an inch beyond their fingertips, a patient who otherwise knows they shouldn't get up alone might feel they have literally no other choice but to try.
Yeah, because if they have to use the bathroom urgently because of that diuretic we talked about, and they can't reach the button to call you, they aren't just going to lay there and wet the bed. Human dignity is a really powerful motivator.
It is. They are going to attempt the journey.
So, rule number 1. The call bell is always in reach, physically resting on them or clipped to their gown. What are the other non-negotiable environmental fixes for the room before you walk out the door?
The bed must be in its lowest possible position, always.
The moment you're done providing care.
The exact moment. You lower that bed until it physically stops. The physics here are simple. If a fall does happen, you want to minimize the distance to the floor. Falling from 14 inches is vastly different from falling from 30 inches.
Lower potential energy means lower kinetic energy on impact.
Exactly. You also need to ensure adequate lighting. There should be no dark, shadowy pathways between the bed and the bathroom. As we discussed, aging eyes need significantly more light to perceive depth and contrast.
And keep the floors clear, right?
Yes, keep all pathways completely clear of clutter. No shoes left in the middle of the floor, no oxygen tubing looping across the walking path, and certainly no spilled liquids. Finally, ensure grab bars are installed and accessible in the bathroom, and that the patient actually knows they are there.
Let me push back on something here, because this is a trap I see students fall into all the time when they're trying to solve a problem logically.
Okay, let's hear it.
If I have this 82-year-old patient we've been talking about, and they are confused, and they are highly unsteady, shouldn't I just put all the side rails up on their bed? Doesn't that just mathematically solve the problem? Like, keep them boxed in so they literally cannot fall out.
I love that you are bringing this up. This raises an incredibly important question, and it is arguably one of the most common and most dangerous exam mistakes a student can make.
Wait, really?
Yes. The answer is a firm, hard no. You do not just put all the side rails up.
But why not? From a purely protective standpoint, it feels like the safest thing to do. It feels like, I don't know, putting a baby in a crib.
It feels safe to the caregiver, but statistically and clinically, it is incredibly dangerous to the patient. First of all, we have to look at this legally.
Okay.
Using all the side rails to keep a patient in bed against their will is considered a physical restraint, and CNAs cannot, under any circumstances, apply physical restraints without a specific, direct written order from a nurse or a doctor.
Okay, that makes sense. That's a strict scope of practice issue. You don't have the authority to restrain someone.
But secondly, and honestly more importantly, think about the psychology of that confused 82-year-old patient. They wake up in the dark, they desperately want to get to the bathroom, they swing their legs over, and they find a metal barrier.
Right.
Do they just say, oh, I guess I'm trapped here, I'll just go back to sleep?
Usually no, especially if they are confused or agitated.
Almost never. They try to climb over the side rails, and now think about the biomechanics of what you've just forced them to do. Instead of simply sliding out of a low bed and maybe rolling onto the floor from a height of 18 inches, which, might cause a bruise, they are now straddling a metal bar.
Oh, man.
They lose their balance, and they fall from 3 or 4 feet in the air, often head first or landing squarely on a hip. The injuries resulting from patients climbing over side rails and falling are catastrophically worse than rolling out of a low bed.
Wow. Okay, That is a terrifying visual, but it makes the reasoning click perfectly. You aren't preventing a fall. You are literally just increasing the altitude of the fall.
Exactly.
So side rails are only used as ordered by a nurse for specific high-risk patients, or maybe you leave one half rail up to help a patient physically grip something to reposition themselves in bed, but never as a blanket default to keep someone trapped.
You've got it. Bed low, call bell in reach, room well lit, pathways clear. Those are your universal daily defaults. Those are the invisible safety nets you weave into every single room you enter.
So we've secured the room. But what happens when we actually need to get them up and moving? Let's shift our focus into gravity, gait, and safe patient handling. Because getting a weak, unsteady patient out of bed and walking them down the long, hard-tiled hallway is, well, it's incredibly nerve-wracking.
It is, and it should be. You're fighting gravity every step of the way. And the most important, indispensable tool you have for ambulation is the gait belt.
The gait belt.
But here's the catch. Simply having the belt strapped around their waist isn't enough. You have to know precisely how to use it, how to grip it, and exactly where to position your own body in relation to theirs.
Okay, give me the mental visual. I want to see it. I'm putting the gait belt on the patient. It goes over their clothing, not on bare skin, right?
Correct.
Yeah.
Over the clothing.
It's snug, but I can comfortably fit a couple of flat fingers under it to ensure it's not restricting their breathing. Now, they're standing up, and we're about to walk to the dining room. Where do I, the CNA, stand?
You need to grip the gait belt firmly, not just a loose, casual hold in the back with one hand. You want an underhand grip on the sides or the back. And you, as the CNA, must position yourself slightly behind the patient and strictly to their weaker side.
Slightly behind and to the weaker side. Why that specific geometry? Why not stand right next to them like we're just walking down the street together, or maybe slightly in front to lead the way?
Because it's entirely about controlling their center of gravity in a crisis. If they start to buckle or lose their balance, it is almost always going to be on their weak side.
That makes sense.
Right? If you are standing in front of them, pulling them forward, you have absolutely no leverage if their knees give out. You'll just get pulled down right on top of them. If you are walking independently behind them with no hands on the belt, you simply cannot react fast enough to catch them before they hit the floor.
So being behind and on the weak side gives you the advantage.
Being slightly behind and on the weak side allows you to use your own body as a structural brace. You can pull their shifting center of mass against your own core for support.
I always compare this to being a spotter at a gym. Like if you are spotting someone who is doing a really heavy barbell squat, you don't stand in front of them staring at their face while they lift.
No, that would be useless.
You stand right behind them, practically mirroring their movement. You're ready to absorb that massive downward momentum and guide the weight if their legs suddenly give out.
That is a brilliant analogy. You are not doing the lifting for them, but you are positioned to instantly manage the load if their primary support system, their own legs, fails.
Which brings us to the nightmare scenario. We are walking down the hallway. I'm doing everything right. I'm on their weak side. I'm slightly behind them. I've got a firm underhand grip on the gait belt. And suddenly, their knees buckle.
It happens fast.
Right. Maybe that blood pressure drop just hit them. They go limp and start to go down. What is my immediate reaction? Because my deeply ingrained human instinct is to yank them back up by the belt or to try and catch them under the armpits to physically stop them from hitting the floor.
And you must fight that instinct with every ounce of willpower you have. Do not try to catch them. Do not try to prevent their downward movement.
But wait, I'm supposed to protect them. If I let them fall, haven't I failed at my job?
You are supposed to protect them from severe injury, not necessarily from gravity itself, once gravity has already won the battle. Think about the physics again. If a 150-pound or a 200-pound person goes limp and is in free fall, and you try to stop that dead weight abruptly with your arms or your lower back,
I'm going to get hurt.
You are going to tear your own muscles, rupture a spinal disc, and guess what? The patient is still going to fall. Only now you are injured, and you might lose your balance and fall right on top of them, crushing them.
Okay, that is a terrifying reality check. So if I can't catch them, what is the actual right move? How do I protect them?
The correct protocol is called a controlled descent. You already have a firm, locked grip on the gait belt. The second you feel them going down, you widen your stance immediately to create a solid base of support and protect your own back.
Widen the stance. Got it.
You pull the patient's weight slightly backward, pinning them against your own body to stabilize them. If you are near a wall, you can try to guide them toward it so they can slide against it.
But eventually they have to hit the floor.
Yes, but you let gravity do its work while you act as the anti-lock brakes. You bend your knees, never your back, and you slide them gently and securely down your own leg to the floor in a smooth, controlled manner. You are protecting their head at all costs, ensuring it doesn't strike the tile.
So you are basically piloting their crash landing.
Exactly. You are taking a violent, unpredictable high-velocity impact, and you are turning it into a slow, gentle, guided slide. You are minimizing the trauma of the event.
Okay, so the controlled descent is successful, and now the patient is sitting or lying on the floor. Or, let's look at a different, very common scenario. You walk into a room to do your rounds, and you find a patient already lying on the floor next to their bed. You didn't see the fall happen. What is the very first step you take?
Do not move them. Under any circumstances, do not try to get them up off the floor.
Even if they are wide awake talking to me and saying, "Oh, I'm so embarrassed, I'm totally fine, please just help me stand up."
Especially then, you have to remember that elderly patients or patients with certain degenerative bone conditions like osteoporosis can sustain severe fractures from a seemingly minor impact.
Even from a short distance.
A hip fracture or even a hairline spinal injury
Yeah.
can occur from simply rolling out of a low bed. And because of the adrenaline and shock of the fall, or maybe underlying cognitive issues, they might not feel the pain immediately.
So if I grab their arm and say, "Okay, let's heave-ho and get you back into bed."
If you have them bear weight on a broken hip, a relatively clean minor fracture can instantly become a jagged compound fracture, tearing through muscle and blood vessels. A stable minor spinal injury can shift and become a paralyzing one. The damage done by moving a patient improperly after a fall can be infinitely worse than the fall itself.
So I just leave them lying there on the cold linoleum. That feels, I don't know, kind of wrong.
You don't abandon them, you stay with them. You get down on the floor with them, you talk to them, you keep them calm, perhaps slip a pillow under their head if it's safe to do so, and you use your call bell or your voice to notify the nurse immediately.
Because the nurse has to assess them.
The nurse has the clinical training to perform a full assessment checking for limb rotation, pupil response, signs of internal bleeding, to rule out major injuries before anyone attempts to move that patient an inch.
Okay, let's shift gears and talk about moving patients when things aren't an emergency. Mechanical lifts, the Hoyer lifts, the sit-to-stand machines. These are incredible pieces of engineering, but they intimidate a lot of new CNAs, and honestly, they terrify some of the patients.
They absolutely should command respect. When you use a mechanical lift, you are suspending a human being in midair. The core rules for any mechanical lift operation are strictly non-negotiable.
All right, what's rule number one?
First, you must ensure you are operating on a completely stable, flat surface.
Sure.
You never attempt to lift on an incline. Second, and this is a point the exam will hit you on repeatedly, never operate a mechanical lift alone.
You always need two people.
It almost universally requires 2 trained staff members for safe operation.
Because it's too much to manage mentally and physically at once, right? You need one person entirely focused on operating the hydraulics or the machinery, and the other person physically guiding the patient and the sling, ensuring they aren't swinging into the machinery.
Exactly. You need 2 sets of eyes, one watching the mechanics, one watching the patient's face and body alignment.
Let's talk about the psychological aspect of this for a second. If you are an elderly patient and you've lost your mobility, and now 2 people are strapping you into a canvas sling and literally hoisting you into the air with a crane, that has to be terrifying.
It is incredibly disorienting. They feel entirely helpless. That's why your communication during a lift is just as important as your physical technique. You must explain every single step before you do it.
Narrating the process.
Yes. Okay, Mr. Johnson, we have the sling secure. I'm going to start lifting you now. You're going to feel yourself rise off the bed.
Yeah.
You maintain eye contact. You offer constant reassurance.
So what if there's a mid-lift emergency? You've got the patient suspended a foot over the bed, you're moving the crane toward the wheelchair, and suddenly the patient starts slipping out of the bottom of the sling or they start screaming in sudden sharp pain.
That's a bad situation.
My immediate instinct would be to just hit the button, speed up the machine, and drop them into the chair as fast as possible to end the stressful transfer.
That is a very natural panic response, but it is absolutely the wrong move. If a patient is slipping or if they are reporting sudden pain, you stop the lift immediately. Do not speed up.
Don't rush it to get it over with.
No. Speeding up increases the erratic swinging movement of the sling. It increases the patient's panic, and it exponentially increases the risk of them falling out entirely.
So I just freeze the machine.
You stop the machine's movement. You loudly call for your second assist if they stepped away for some reason, and you reassess. You also cannot just say, forget the machine, and try to switch to manual lifting midair by grabbing them under the arms.
Right, because then you're bearing all their weight.
You must stabilize the machine, slowly lower them back to the nearest safe surface, which is usually the bed they just came from, and completely readjust the sling placement before trying again.
What about bed transfer boards? The smooth, flat slide boards you use to bridge the gap and slide someone from the edge of the bed over to a wheelchair.
Those require meticulous, geometric setup, and you can guarantee the exam will test you on the specifics of this setup. First and foremost, you must lock the wheels on both the bed and the wheelchair.
Because if either one of those rolls away while the patient is halfway across the bridge,
It's a catastrophic fall straight down between the two surfaces. Total disaster. You lock the brakes, and then you physically push on both the bed and the chair to test that the brakes are actually holding. Secondly, you must ensure the bed and the wheelchair are at the exact same height.
why does the height have to be exact? Can't the bed just be a little higher to make sliding easier, like a gentle slide?
If you are trying to slide a patient uphill, you are going to severely strain your back and shoulders. If you are sliding them downhill on a steep angle, gravity takes over. They will gain too much momentum, slide straight across the board, and potentially slide right off the other side of the wheelchair onto the floor.
Ah, okay. That makes sense.
Same height, wheels locked, smooth, controlled slide.
It's all about physics, really. It's about eliminating the unpredictable variables, which actually flows perfectly into the next area we need to cover. Let's talk about the variables in the broader environment. Hazards, spills, and the incredibly strict boundaries of your scope of practice as a CNA.
This is crucial.
Because a huge part of safety is knowing exactly what you shouldn't touch.
That's a great way to frame it. You are the first line of defense in identifying a hazard, but you are not always the authorized person to neutralize that hazard.
Let's start with the mundane basics. Immediate environmental hazards. I'm walking down the hall, or I'm doing rounds in a patient's room, and I see a puddle of spilled water on the floor. What is my immediate action?
You wipe it up immediately yourself, and you place a yellow wet floor sign directly over the area until it is completely dry.
I don't go down the hall to find the housekeeping cart. I mean, it's literally their job to mop the floors.
You absolutely do not leave the spill to go look for housekeeping. Think about the timeline. If you walk away to find a janitor, it might take you 30 seconds. In those 30 seconds, a patient with a walker, a visiting family member, or a nurse carrying a tray of medications could turn the corner, slip on that puddle, and fracture their skull.
So it's my responsibility right then.
You secure the hazard immediately. You are responsible for the environment you're standing in.
Okay, what if the hazard isn't just water? What if I see a frayed electrical cord on a piece of equipment? Like the thick power cord on the mechanical lift is exposing bare copper wires, or the patient's IV pump has a cracked and damaged plug.
That is a massive shock hazard and a severe fire hazard. You report it to the charge nurse immediately, and you do not use the equipment.
Can I just wrap some electrical tape tightly around it so we can finish the transfer?
Never. You do not attempt amateur repairs on medical equipment. Electrical arcing from a frayed cord can ignite oxygen in the room or deliver a lethal shock to you or the patient. You unplug it if it's safe to do so, you tag it as broken, you take it completely out of service, and you alert the nurse.
Let's talk about a hazard that isn't as obvious as a sparking wire or a puddle on the floor. Bathing risks. What is the magic, non-negotiable number for water temperature when drawing a bath or a shower for a patient?
This is critical, especially in long-term care settings. Bath water must be 110 degrees Fahrenheit or 43.3 degrees Celsius or less.
Why that specific number? I mean, honestly, 110 degrees isn't even that hot. I like my showers way, way hotter than that at home.
You might, and your skin can handle it. But we have to do a deep dive into the physiology of aging skin here. As human beings age, the epidermis, the outer layer of skin, thins out dramatically.
It gets almost paper thin.
Exactly. And furthermore, we lose that thick protective layer of subcutaneous fat underneath. The skin becomes almost like fragile parchment paper.
So it literally has less physical defense against heat.
Exactly, and it gets more complicated. Many elderly patients suffer from decreased sensory perception. This could be due to diabetic neuropathy, where the nerves in their extremities are damaged, or simply poor peripheral circulation.
So their brain isn't receiving the pain signal as quickly. They might not even realize the water is literally burning them until the physical damage is already done.
Precisely. If you or I put our hand under 120-degree water, our nervous system screams hot tea, and we instinctively yank our hand back in a fraction of a second.
Right.
An elderly patient might casually leave their foot in that same 120-degree water, feeling only a dull warmth, while second-degree scald burns are actively forming on their thin skin. 110 degrees is the absolute maximum safe threshold to prevent severe scalding. You must test the water temperature yourself, usually with a specialized thermometer or the inside of your wrist, before the patient ever touches it.
That physiological explanation makes the rule make so much sense. It's not arbitrary. Okay, let's get into the tricky stuff. The scope of practice boundaries. This is where I see really well-meaning students get tripped up on exams because their human instinct is just to be helpful and clean things up.
It's a common trap.
Let's set a scenario. I'm helping a patient get situated in bed. I reach across the bedside table, and my elbow accidentally knocks their little plastic medication cup off the table. A pill rolls under the bed, or maybe some bright pink liquid medicine spills all over the linoleum.
Okay, I see where this is going.
My immediate helpful instinct is to grab a paper towel, wipe it up, throw it in the trash can, and go tell the nurse, "Hey, so sorry I knocked over the cup. I need a replacement dose."
If you follow that helpful instinct, you have just severely violated several strict facility protocols, and you have potentially violated federal law regarding medication disposal.
Wait, really? Just by cleaning up a spilled Tylenol or whatever it was?
Yes. CNAs must never, ever handle medications. Not to administer them and not even to clean them up. Medications have incredibly strict chain of custody rules governed by the DEA and facility policy.
Oh, because of narcotics and stuff.
Right. If a pill falls on the floor, especially if it is a controlled substance like a narcotic painkiller, and you simply throw it in the regular trash or flush it down the toilet, there is absolutely no proof of where that medication went.
Oh, I see. Because from an administrative standpoint, it looks exactly like I just pocketed the pill.
Exactly. It can easily be suspected as medication diversion, which is the legal term for a healthcare worker stealing drugs. You cannot break that chain of custody.
So what should I do instead?
If a medication spills, you must freeze. You physically guard the spill so no one else steps on it, slips on it, or in a dementia unit, picks it up and eats it. You use your call bell to notify the nurse immediately.
And the nurse cleans it.
The nurse must be the one to come in, visually assess the spilled medication, document the waste precisely according to legal standards, and dispose of it in a designated, secure pharmaceutical waste container, not the bedside trash.
Wow. Okay. So I drop a pill, I stand guard like a sentry, and I call the nurse. I do not touch the pill.
You do not touch it. You let the authorized personnel handle it.
What about 5V lines? Say I'm changing a patient's gown, trying to thread it carefully, but somehow the IV tubing catches on the fabric. The tape rips, the needle pulls completely out of their arm, and bright red blood starts dripping rapidly onto the clean white bed sheets.
A scary moment for sure.
Now, I know basic first aid. I know how to put a Band-Aid on, and I know how to plug a little plastic tube back into a port. Should I just quickly fix it to stop the bleeding and save the nurse a trip?
Absolutely not. Reinserting, adjusting, or even silencing the alarm on an IV pump is strictly a nursing task. It requires complex assessment of the vein to ensure it hasn't blown, and it requires strict sterile technique to prevent introducing a massive bloodstream infection directly into the patient's heart.
So what is my role in that chaotic moment with the blood dripping everywhere?
Your role is immediate, localized first aid within your scope of practice. You grab a clean cloth or gauze, you apply firm, direct physical pressure to the bleeding puncture site on the patient's arm to stop the blood loss, and you use your call bell to notify the nurse instantly.
I shouldn't even try to pinch the IV tubing closed so it stops leaking fluid everywhere, or mess with the pump buttons to stop the beeping.
No. You apply pressure to the patient, you secure the patient's safety, and you call the nurse. Let the nurse handle the sterile equipment and the machinery. Your focus is the human being bleeding.
Speaking of equipment, a quick clarifying question. When am I actually supposed to check that things like wheelchair brakes or walker grips are working? Do I just wait for a patient to complain that their wheelchair brake feels a little loose?
You must check all care equipment for damage and proper mechanical function before you use it. Every single time.
Every time.
It should become an automatic habit. If you wait for a patient to complain that the brake is loose, it usually means the brake has already failed while they were relying on it, which means the patient was already put at severe risk.
Proactive safety versus reactive safety. I really like that framing. Okay, what about managing patient behavior safely? Because this is where clinical safety protocols crash headfirst into the reality of human free will.
Yes, the human element.
Let's say a patient has a strict doctor's order to use a walker. They are a known, documented fall risk. But today, They are feeling incredibly stubborn. They look at you and say, I am not using that ugly, clunky thing today. I am walking to the dining room on my own 2 feet. Can I physically force them to hold on to the walker?
No, you cannot physically force them to grip the walker, and you certainly cannot threaten them or scold them like a child. As a healthcare worker, you have to balance safety with the patient's fundamental legal right to autonomy.
Even if it's dangerous for them.
They have the right to refuse care, and they have the right to refuse medical devices.
But I know they're going to fall. If I let them walk without it, aren't I being negligent?
They might fall. It's a real risk. But forcing a medical device on them against their expressed will violates their civil rights and could legally be construed as battery or assault. Your required response is a three-step process: educate, monitor, and document.
Walk me through that 3-step process.
First, you clearly and calmly explain the medical reason for the device. You say, Mr. Smith, the doctor ordered this walker specifically because it helps keep your balance steady so you don't fall and hurt your hip again. You strongly, positively encourage its use.
But if they plant their feet and still refuse?
You do not physically engage in a tug-of-war. You step back, you walk right alongside them, monitoring them incredibly closely, ready to perform that controlled descent we talked about if they lose balance. And the second they are seated safely, you notify the nurse immediately.
So the nurse can officially document the refusal of the medical device.
Exactly. The nurse will document the non-compliance, and the interdisciplinary team may need to adjust the care plan. Your job is to facilitate their safe movement as best as possible without violating their autonomy.
What if it's a patient with advanced dementia? The rules of autonomy get a little blurrier there. Let's say they are wandering. They have no idea what year it is or where they are, and they are aggressively trying to leave the secure unit. They keep pulling on the heavy exit doors.
A very challenging scenario.
What is the safest way to handle that environment? I mean, my instinct would be, can't we just lock the heavy doors with a deadbolt so they physically can't get out into the street?
You absolutely cannot just unilaterally lock unit doors with standard locks or deadbolts to trap patients inside. The only exception is if it is an explicitly approved, fire marshal-cleared magnetic lock system that is electronically tied directly to the building's fire alarms.
Meaning the second a fire alarm goes off, those magnetic locks automatically disengage.
Yes. Slapping a padlock or a deadbolt on a door is a massive, highly illegal fire code violation.
Because if there is a fire and the staff member with the key is incapacitated,
then everyone in that unit burns. If there's an emergency, every single person needs to be able to push that door open and evacuate. You cannot trap human beings in a building.
so how do I stop the dementia patient from wandering out into traffic if the door isn't deadbolted?
Calm, persistent redirection. You don't argue with them. You don't logically try to convince them they live in a nursing home now. That will just cause massive distress. You don't tell them they are trapped.
You just guide them away.
You physically walk over to them, gently guide the conversation to a pleasant topic from their past, maybe offer a cup of coffee or ask for their help folding some towels. And you physically redirect their walking path away from the exit door. And, of course, you notify the nurse so the entire care team is aware of the increased wandering behavior that shift.
It's all about psychological de-escalation and maintaining the flow of the environment. But speaking of the environment, and you just mentioned fire codes, let's transition into our final major topic area today. Code Red. Fire safety, oxygen hazards, and large-scale disaster evacuation.
The real high adrenaline stuff.
Because when that piercing alarm goes off and the strobe lights start flashing, there is zero time to open a manual and check what you're supposed to do.
None whatsoever. Your brain will be flooded with adrenaline. You have to rely entirely on drilled muscle memory and the specific acronyms you've memorized.
I mean, if there's one thing I know Cert Prep Academy flags as an incredibly high-frequency exam topic, it's these FIRE acronyms. You are practically guaranteed to see questions about Race E and pass on your test.
Without a doubt. They are the universal language of healthcare fire safety. Let's break them down logically. Race E is your step-by-step protocol for what to do the moment you discover a fire. RACE. Rescue, alarm, confine, extinguish.
Okay, well, let me test you with a specific scenario, because this trips a lot of people up when they think about the greater good versus the individual.
All right. Lay out the scenario.
I walk into a patient's room, and the plastic trash can right next to their bed is on fire. Maybe a visiting relative dropped a smuggled cigarette in there, and the paper is blazing. My immediate logical instinct is to yell for help, run out to the hallway, smash the red fire alarm on the wall to alert the entire building, and then run back in to deal with the patient. Isn't hitting the alarm the absolute most important thing to save the hundreds of people in the facility?
It is vitally important for the facility, but it is unequivocally not the first thing you do. The R in RACE stands for rescue.
So I have to get the patient first.
If a specific patient is in immediate proximal danger, and a blazing fire in the trash can 2 feet from their bed is immediate danger, your very first action before you do anything else is to physically rescue and evacuate that specific patient from the room.
Over pulling the alarm, why?
Because of the sheer physics of how fire and smoke behave in an enclosed room. Fire consumes oxygen rapidly, and it produces highly toxic superheated gases. Smoke layers at the ceiling and descends incredibly fast.
So if I leave them,
If you turn your back, run down the hall to pull the alarm, and wait for the elevators to shut down. It might only take 20 or 30 seconds. But in those 30 seconds, that patient could inhale enough toxic smoke to suffer fatal lung damage. You grab the patient, you get them out in the hallway past the fire doors, and then you hit the alarm, the A.
rescue first, then alarm. Then C is confine. How do I confine a fire without a hose?
By closing doors. It is incredibly simple but incredibly effective. Once the room is evacuated, you firmly pull the heavy patient room door shut behind you.
Oh, because that chokes it out.
Fire needs 3 things to survive: heat, fuel, and oxygen. By closing the door, you are drastically cutting off the oxygen supply to the fire. You are also physically trapping the thick, blinding smoke inside that specific room, which keeps the main hallway clear so the rest of the facility can evacuate safely. Compartmentalization saves lives.
Rescue, alarm, confine, and finally, E is extinguish.
Yes, but with a massive asterisk. You only attempt to extinguish the fire if you're specifically trained on the equipment, only if the fire is small and contained, like entirely inside that trash can, and only if you have a clear, unblocked escape route behind you.
So if it's already climbing the walls.
If the fire has already climbed the curtains or is spreading across the ceiling, you do not try to be a hero with a tiny extinguisher. You turn your back and you evacuate.
Which brings us to the second crucial acronym, PASS. Like we saw on that Cert Prep Academy practice test, if I do decide it's safe to fight that small trash can fire, PASS is how I actually operate the red fire extinguisher on the wall. PASS? Pull, aim, squeeze, sweep.
Exactly. First, you pull the metal safety pin out of the handle. Next, you aim the nozzles at the very base of the fire, where the fuel is. Do not aim at the top of the dancing flames, you have to hit the source.
The base of the fire, got it.
Then, you squeeze the handle firmly to release the extinguishing agent. And finally, you sweep the nozzle forcefully from side to side to completely blanket the fuel source.
And we need to know the different types of extinguishers, right? Like, if I see a fire, can I just grab any red canister off any wall and start spraying?
No, and this is highly critical in a modern hospital or long-term care setting, which is basically packed wall-to-wall with high-voltage machinery. You need to know that a Type C fire extinguisher is strictly required for electrical fires.
What does it matter? Doesn't all the stuff in the canisters put out fires?
It matters because of electrical conductivity. Type C extinguishers use specially formulated non-conductive dry chemicals. Let's say an IV pump has sparked and is on fire and it's still plugged into the wall. If you grab a standard water-based extinguisher, a Type A, and spray a solid stream of water onto that sparking live electrical equipment.
Water conducts electricity.
Exactly. The stream of water creates a direct, unbroken conductive bridge from the high-voltage outlet straight up the stream of water into the metal canister you are holding and directly into your heart. You'll be violently electrocuted. Type C dry chemicals smother the fire without creating an electrical circuit.
Type C for current, electrical current. That's a really easy, vivid way to remember it for the exam. Okay, so the alarm is pulled, the heavy fire doors have slammed shut, and now the entire facility has to evacuate. What are the logistics of moving hundreds of frail people? Who goes first?
Evacuation is a highly choreographed, military-style operation. The order of evacuation is always based strictly on proximity to the danger. The patients nearest the fire, the ones in the immediate adjacent rooms, are evacuated first. Then you move outward in concentric circles.
And what about the nursing staff and the CNAs?
The staff leaves last. Only after every single patient room, bathroom, and closet has been physically cleared.
What do I do with the ambulatory patients, the ones who can walk perfectly fine on their own? Do I just tell them to run outside?
No. You guide them firmly to the nearest safe, smoke-free exit, and you specifically direct them to the facility's designated assembly area.
Not just out into the parking lot to get away from the building, or to the cafeteria in the next wing.
Never randomly into the parking lot. The designated assembly area is absolutely critical because that is where the charged nurses and administration will perform a rigorous head count based on the census.
The head count.
Think about this from the perspective of the fire department. If a confused ambulatory patient wanders off into the far corner of the parking lot and isn't counted in the official assembly area, the administration will report to the fire chief that a patient is missing inside the building.
Oh, wow. And then the firefighters?
The firefighters will risk their own lives, entering a burning, collapsing structure to frantically search for someone who is already sitting safely outside by a parked car. The head count is literal life or death. You must keep the patients contained in the assembly area.
I never thought of it that way. The cascading consequences are huge. What if I am trying to evacuate a patient who doesn't speak a word of English? The strobe lights are flashing, the alarm is deafening, they are terrified, and they don't understand my shouted instructions. Should I run down the hall to find the Spanish translator or the translation iPad?
Absolutely not. You do not waste precious seconds looking for an interpreter while smoke is filling the hall. In an acute emergency, you rely entirely on kinesics nonverbal communication.
Hand gestures and stuff.
Yes. You use firm, clear, exaggerated hand gestures pointing to the door. You make reassuring eye contact, and you physically gently guide them by the elbow or the arm out of the room and toward the exit. And remember, during any fire alarm, you never, ever use the elevators. Elevator shafts act like chimneys for toxic smoke. Stairs only.
Let's talk about a different kind of invisible fire risk that is everywhere in a facility. Oxygen therapy. We see those green oxygen tanks and the clear tubing everywhere. What are the absolute safety rules here?
The most fundamental rule is understanding the chemistry of what oxygen actually does. Oxygen gas itself doesn't just burn on its own, it vigorously accelerates combustion.
So it makes fires worse.
It makes small fires burn infinitely hotter and faster. If a tiny spark from a frayed wire or static electricity or a smuggled cigarette hits an oxygen-rich environment, it can cause an instant violent flash explosion. Therefore, oxygen must be kept strictly, religiously away from open flames, matches, lighters, and any smoking materials.
Okay, here's a scope of practice nuance that I want to clarify, because this can be tricky on the exam. We talked earlier about how CNAs absolutely cannot touch IV lines if they get disconnected. What if I walk into a room and the patient's clear oxygen tubing has simply popped off the little green nozzle on the wall because they pulled it too hard? Can I plug that back in, or do I have to stand there and wait for the nurse while my patient is potentially gasping for air?
This is a really great distinction, and I'm glad you brought it up. While you cannot adjust complex, sterile things like IVs, if a standard oxygen tube simply physically disconnects from the wall source or the concentrator, the CNA can, and absolutely should, manually reconnect it immediately.
Oh, good.
Reconnecting the plastic tubing is a basic, life-saving environmental safety measure. It does not require sterile technique.
So I just firmly pop the plastic tube back onto the nozzle.
Yes. You reconnect it, you ensure the oxygen is flowing, and then you closely monitor the patient's face and chest for any signs of respiratory distress. And of course, you inform the nurse that it happened. However, and this is the incredibly strict red line boundary, you cannot, under any circumstances, adjust the oxygen flow rate.
The little dial with the numbers on it?
Exactly. If the dial on the wall says 2 liters per minute, and the patient looks at you, says they feel a little short of breath, and asks you to just turn it up to 4 liters to help them out, you cannot touch that dial.
Even if they're asking for it.
The specific flow rate of oxygen is legally classified as a medication prescription. Only a doctor can prescribe it, and only a nurse or respiratory therapist can administer or adjust it. If you change the dial, you are illegally practicing medicine. You get the nurse.
Reconnect the disconnected tube to save a life, but never, ever touch the medication dial.
Got it. Okay, let's wrap up this deep dive with some other large-scale natural disasters and localized medical emergencies. Because a fire isn't the only time things go violently sideways. What if the facility is suddenly under a tornado warning and the sirens are going off outside?
During a tornado warning, the immediate physical threat is flying glass and heavy structural collapse from high-velocity exterior winds. So your primary goal is to get the patients as far away from the exterior shell of the building as possible.
Move them to the middle.
You rapidly move bedridden patients, bed and all, into interior hallways, away from all exterior windows. If they're ambulatory, you move them to interior windowless rooms like large bathrooms or specialized reinforced storm shelters on the lowest possible floors. And you close all heavy doors to create more barriers against flying debris.
What about the exact opposite problem? A massive flood. The river is rising and water is starting to enter the first floor of the facility. A flood requires the exact opposite vertical strategy. You move patients up. You relocate them to higher floors using whatever available equipment you have, wheelchairs, stretchers, or even carrying them, following the facility's specific evacuation disaster plan.
Makes sense. Head for high ground.
But there is a massive safety rule here that people often violate out of panic.
Hmm.
Do not try to play the hero and push a patient in a wheelchair through active, rising floodwaters to get to an exit.
Why not? If I look outside and the water in the parking lot is only like 6 inches deep, I could easily push a chair through a puddle.
Because floodwater's opaque, and you have absolutely no idea what is under that 6 inches of water.
Hmm.
A manhole cover could have washed away, leaving a 10-foot drop right where you were stepping.
Oh, wow. I didn't think of that.
Furthermore, 6 inches of fast-moving water has enough kinetic force to sweep a grown adult completely off their feet. And from a biohazard standpoint, floodwater is instantly contaminated with raw sewage, agricultural chemicals, and hidden live electrical currents from downed power lines. You do not enter the water, you stay dry, and you move up.
That is terrifying, but it makes total sense. You respect the water. And finally, let's talk about a highly localized, sudden medical emergency. A patient starts having a massive grand mal seizure right in front of me while we are sitting in the dining room. What is the immediate drilled CNA protocol?
First, we have to understand what a seizure is. It is a violent, uncontrolled electrical storm inside the patient's brain. You cannot stop it once it starts.
So you just have to ride it out.
So your primary, singular goal during an active seizure is to protect the patient from physical trauma while the seizure runs its terrifying course. First step, instantly clear the area of any hard hazards. Push away heavy wooden chairs, pull the dining tables back, move anything hard or sharp that their flailing limbs or head could forcefully strike against.
Should I try to straddle them or hold their arms and legs pinned to the floor so they don't thrash around and hit the hard tile too hard?
Never, ever hold them down. The muscle contractions during a seizure are incredibly violent. If you physically restrain a convulsing limb, the sheer force of their own muscles pulling against your grip can cause severe muscle tears, dislocated joints, or even shatter their own bones. You have to let the body move.
What about their airway? I feel like I've seen in 100 movies where someone grabs a leather wallet or a wooden spoon or a rolled-up belt and shoves it into a seizing person's mouth so they don't accidentally bite their own tongue off.
That is one of the most persistent and most incredibly dangerous medical myths out there. Never, ever put anything, not a spoon, not a wallet, not your fingers, into a seizing patient's mouth.
Not even to protect their tongue.
The jaw muscles lock down with bone-crushing force. They could easily bite down, shatter their own teeth on the spoon, and then inhale the broken shards of tooth into their lungs. Or they could simply choke on the object itself.
So if I can't hold them down and I can't put anything in their mouth, what do I do while they are convulsing?
What you do is protect their head. Slip a soft jacket or a thin pillow under their skull so it isn't hammering the tile. And crucially, as soon as it is physically possible, you gently position the patient onto their side. This is called the recovery position.
Why specifically roll them onto their side?
It is entirely about protecting their airway from fluids. During a severe seizure, a patient will often vomit, or they will produce massive amounts of thick, foamy saliva, and they cannot actively swallow.
So they could choke.
If they are lying flat on their back, gravity will force that vomit or saliva straight down the back of their throat. They will aspirate, meaning they will inhale that toxic fluid directly into their lungs. This can cause immediate choking or a highly lethal condition called aspiration pneumonia a few days later.
But on their side.
By rolling them onto their side, gravity works for you, allowing the vomit or saliva to safely drain out of the corner of their mouth onto the floor. Roll them on their side, protect their head, look at your watch to aggressively time the exact duration of the seizure, and have another staff member urgently notify the nurse.
Wow. We have covered a truly massive amount of ground in this deep dive. From the seemingly mundane hazards of a spilled cup of water to the complex physics of a mechanical lift, all the way to the sheer adrenaline of a facility fire or a massive seizure. Let's do a rapid-fire focused recap of the most critical takeaways we discussed today so our listeners have it locked in.
Let's do it. Number 1. The call bell is your absolute best, most effective tool for fall prevention. Keep it physically in the patient's reach at all times. It empowers them to ask for help instead of taking dangerous risks.
Number 2, beds stay in their lowest possible position to the floor. Side rails are not your default easy options. Using them to keep a patient in bed is legally a restraint unless ordered otherwise, and climbing over them causes catastrophic high-altitude falls.
Number 3. When you are assisting a patient with walking, you must grip the gait belt firmly with an underhand grip on the sides, and you position your body slightly behind and strictly on the patient's weaker side to control their shifting center of gravity.
Number 4, if someone is actively falling, fight your human instinct to catch them. You will only destroy your own back. Instead, widen your stance, pull them close to your center of mass, and execute a controlled descent, guiding them safely down your leg to the floor. And once they are on the floor, do not move them an inch until the nurse physically assesses them for hidden fractures.
Number 5. Remember, race rescue, alarm, confine, extinguish. In a fire, prioritize rescuing the specific patient in immediate danger above all else. Compartmentalize the smoke by closing doors, and never use the elevators.
And number 6, fiercely respect the boundaries of your scope of practice. You can reconnect an oxygen tube to a wall to save a life, but you can never touch the medication flow dial. You can apply direct, firm pressure to a bleeding, ripped-out 5V, but you can never attempt to reinsert it. And you must never, ever clean up a spilled medication and throw it in the trash, breaking the legal chain of custody.
Exactly. Safety isn't just a chapter in a textbook. It is a rigorous daily discipline. And I want to leave you with a provocative thought to ponder as you finish listening to this session.
I love these.
When you are done studying today, I want you to look closely at your own home environment. Look around the living room you are sitting in, or your kitchen, or your bedroom. How many fall hazards or fire risks can you spot right now, just in your immediate vicinity?
I am literally looking at a tangled laptop cord stretching across my walkway right now, and I didn't even notice it 10 minutes ago.
It's amazing how invisible they are until you look for them. A decorative throw rug with a slightly curled edge that could catch a shuffling foot, a stack of old mail piled dangerously near a space heater, a wet spot near the dog's water bowl. Shifting into a clinical safety mindset isn't just about memorizing a dry protocol for a multiple-choice exam.
Right, it's a way of seeing.
It is fundamentally developing a new lens through which you start seeing the entire physical world. Once you train your brain to spot these hazards automatically, you simply cannot unsee them. And that relentless vigilance, that ability to see the invisible dangers before they happen, is exactly what will make you an exceptional life-saving CNA.
That is such a profound and practical way to look at it. You stop just passively seeing a room and you start actively analyzing a safety landscape. And listen, if you want to put this new safety lens to the test, we actually pulled a lot of today's specific scenarios straight from the practice materials at CERT Prep Academy.
It's the best way to practice.
It really is. If you want to really lock this knowledge in before test day, head over to certprepacademy.com. It is an incredible resource, and it is completely free. There is no sign-up or credit card required to get started. They have a massive 70-question practice test that perfectly mirrors the difficulty and format of the real NNAAP exam.
The questions are spot on.
Plus free, detailed study guides covering every single topic on the test and interactive flashcards to help you drill those key acronyms like RACE and PASS into your muscle memory. Everything you need to pass this exam with confidence is located in one place, and it costs you absolutely nothing. So head over to certprepacademy.com right now. The direct link is right down in the description notes.
It truly is an invaluable resource for cementing the dense material we've talked about today. Practice is how you turn theory into instinct.
Thank you so much for taking the time to study with us today. We know you have a lot on your plate, balancing life and learning, but you are doing the hard and necessary work, and it is absolutely going to pay off on the floor. Join us next time for Session 6 of this deep dive series, where we will tackle Safety Part 2, diving headfirst into the microscopic world of infection control, standard precautions, and bloodborne pathogens. Because remember, on the clinical floor, the biggest dangers aren't always the loud, complex diseases. Sometimes it's just about having the sharp eyes and the steady discipline to safely navigate the muddy waters. Keep studying, stay incredibly safe out there, and we will see you in the next deep dive.